I'm a physical therapist and fellow in training, and today we're going to be talking about spinal radiculopathy. So strap in because we're about to have some fun. There's the learning objectives, so go ahead and take a look at these. Now what we're going to do is I've got some quizzes for you. Stop if you can, take a moment, read this presentation. Once you've read it, here's your question. Based on the current diagnostic criteria, does Michael meet the definition for cervical radiculopathy? And the correct answer is no. He meets radicular pain, not radiculopathy. Radiculopathy requires objective neurologic deficit. Provocation tests alone increase the likelihood, but do not confirm a conduction loss. The CPG distinguishes nerve irritation from nerve dysfunction with a deficit. Therefore, Michael has symptom reproduction without a neurologic deficit, and because of this, it's radicular pain. Question number 2. Stop if you can, read this. Which neurologic finding most meaningfully increases post-test probability of radiculopathy and why? And the correct answer is the diminished reflex. Why? Clustered neurologic findings significantly increase the likelihood. Reflex changes are more specific indicators of nerve root dysfunction than isolated sensory findings. Motor testing may be pain inhibited, whereas reflex asymmetry is less volitional and therefore more diagnostically specific. Reflex loss most strongly supports nerve root compromise. A final question for you. Why is this presentation no longer consistent with isolated radiculopathy, and what is the appropriate next clinical action? The presentation is most consistent with cervical myelopathy, not isolated radiculopathy. Urgent referral is indicated. Radiculopathy is typically unilateral and localized to a single nerve root pattern. The neck pain CPG flags bilateral symptoms, upper motor neuron signs like hyperreflexia and Hoffman's, and gait disturbances as indicators of possible cervical myelopathy requiring referral. Myelopathy reflects spinal cord involvement, is often progressive, and warrants prompt medical or surgical evaluation. Upper motor neuron signs override a prior radiculopathy working hypothesis. Okay, now that we've talked about that, and before advancing, let's talk about the terminology. Finnegan et al. Define radicular pain as pain that, quote, is caused by irritation or inflammation of a spinal nerve root, and it does not require a neurological deficit. It is a symptom mechanism. In contrast to Rule and Rayner state that, quote, radiculopathy refers to the objective loss of sensory and or motor function and a nerve root distribution due to nerve root compromise. That word objective is critical. Radiculopathy requires and reflects impaired conduction. Radicular pain does not. Inflammatory sensitization may produce severe radiating pain even when strength and reflexes are normal. Imaging must be interpreted cautiously. Brindjikji et al. Report that, quote, imaging findings of spine degeneration are present in high proportions of asymptomatic individuals. A disc bulge does not confirm symptomatic radiculopathy. The diagnostic anchor remains an objective deficit, myotomal weakness, diminished reflexes, or sensory dermatomal loss. Without these findings, the presentation is radicular pain. Diagnostic precision matters. Management follows language. With terminology clarified, the next question is which findings actually change the probability? Terulli and Rayner state that, again, quote, the diagnosis of radiculopathy relies on clinical findings of motor, sensory, or reflex changes in a nerve root distribution, but the findings are not equal. They further note that, quote, motor weakness in a myotomal distribution is more specific for radiculopathy than isolated sensory symptoms. Weakness carries the greatest weight. Reflex asymmetry meaningfully improves diagnostic accuracy when nerve root consistent. Sensory findings alone show limited specificity. Critically, in the absence of objective neurologic deficit, the likelihood of clinically significant radiculopathy decreases. The hierarchy: reflex changes, weakness, sensory loss. A normal exam significantly lowers the probability. Probability rises through the convergence of these things, not a single positive test. Once you understand which findings carry weight, the next step is proper sequencing. Because radiculopathy is defined by a conduction deficit, begin with conduction testing. First, assess myotomes. Tarulli et al. Emphasize that, quote, motor weakness in a myotomal distribution is more specific for radiculopathy than isolated sensory symptoms. Second, assess deep tendon reflexes. Reflex asymmetry consistent with root level involvement improves diagnostic accuracy. Third, assess dermatomes for pattern confirmation. Sensory loss supports localization but has limited specificity when isolated. Fourth, screen for upper motor neuron signs. Hyperreflexia, clonus, or pathological reflexes suggest cervical myelopathy and require urgent referral. Finally, perform neurodynamic testing. Weiner et al. State that, quote, the upper limb tension test is most useful to rule out cervical radiculopathy when negative. Motor and reflex concordance provide the strongest localization. Sequence reflects physiology. Conduction first, mechanosensitivity last. Now we translate the findings into localization. Radiculopathy requires objective deficit within a single nerve root distribution. Localization therefore depends on physiological concordance across domains. Motor weakness carries the greatest localizing value. Wrist extension weakness suggests C6. Elbow extension weakness suggests C7. Finger abduction weakness suggests T1. Reflex asymmetry strengthens precision when concordant with motor findings. Diminished brachioradialis reflex supports C6. Diminished triceps reflex supports C7. Thumes et al. Caution that dermatomal sensory testing shows considerable overlap, limiting specificity when used alone. Sensory loss supports but does not establish localization. Confidence rises when weakness, reflex change, and sensory alteration converge within one root. If findings span multiple roots or fail to align anatomically, reconsider the diagnosis. High-yield pattern recognition is not memorizing dermatomes, it is identifying physiologic concordance. Now shifting to lumbar root localization. Radiculopathy requires objective neurologic deficit within a single nerve root distribution. In the lumbar spine, motor findings provide the strongest localizing values. L3-4, knee extension weakness with diminished patellar reflex supports localization. L4, ankle dorsiflexion weakness, often with patellar reflex involvement. L5, great toe extension is the most reliable discriminator. There's also dependable reflex at L5, making motor testing critical. There's no dependable reflex at L5. S1, plantar flexion weakness with diminished Achilles reflex strengthens localization. A single leg heel raise assists confirmation. Electrodiagnostic literature emphasizes that localization depends on concordance across domains, not isolated findings. Sensory findings may support the level, but distal overlap is common in the lower extremity. Localization confidence rises when motor deficit and reflex changes align within one root. Without concordance, reconsider the level or reconsider the diagnosis. At this point, we refine probability through pattern agreement. Pain distribution alone is insufficient. Radicular pain can occur without an objective deficit. Diagnostic accuracy improves when findings localize to a single root and deficits are present across more than one neurological domain. Weakness carries substantial weight because it reflects impaired neural output. Reflex asymmetry strengthens confidence when it aligns with the same root level. Sensory findings may support localization, but dermatomal overlap limits specificity when used in isolation. Clusters of concordant findings substantially increase post-test probability compared to a single positive test. The principle is convergence. Single root distribution supports the diagnosis. Motor plus reflex alignment strengthens it. Sensory findings support but do not confirm. Two or more concordant domains meaningfully increase the likelihood. Radiculopathy is identified through physiologic agreement, not isolated symptoms. Here's another little quiz for you. Go ahead and read this. The answer to the question is C, absence of reflex asymmetry. Remember, cervical radiculopathy is defined by, quote, the objective loss of sensory and/or motor function, and clinically that often includes an altered reflex pattern. Here we have provocation signs that raise the probability, but without an objective deficit, especially reflex change, The safest conclusion is radicular pain or irritation, not a confirmed radiculopathy. Neurodynamic testing must be interpreted carefully. Diagnostic accuracy improves when tests are used in combination rather than isolation. When multiple examination findings converge, post-test probability rises substantially. Neurodynamic tests assess neuromechanosensitivity, not conduction loss. Weiner et al. Report that, quote, the presence of 3 of 4 positive tests was associated with a significant increase in the likelihood of cervical radiculopathy. However, a positive upper limb tension test 1 does not establish radiculopathy without objective motor reflex deficits. A single clinical test confirms a diagnosis. No single clinical test confirms diagnosis. Utility improves when findings converge. Key distinctions. Neurodynamic tests identify mechanosensitivity. Radiculopathy requires a neurologic deficit. Clusters raise probability, and objective deficits confirm physiologic involvement. Without convergence, interpret cautiously. Examination strategy must match irritability. Radicular presentations vary in severity, and management should be tailored to symptom behavior rather than applied uniformly. Repeated provocation in highly irritable cases can worsen symptoms without improving diagnostic clarity. Individual physical tests have limited accuracy when used alone. Repeating aggressive testing does not necessarily increase precision. In high irritability cases, consider the following: stopping at the first concordant reproduction. Avoid repeated neurodynamic or fatigue-based motor testing, and prioritize reflexes and light touch. In moderate irritability, cluster testing is appropriate. Limit your repetition and monitor symptom latency and recovery. In low irritability, full cluster testing and repeated loading are typically tolerated. The principle is probability over provocation. Diagnostic reasoning does not require maximal symptom reproduction. Clinical precision includes knowing when to stop testing. Now let's examine the Weiner cervical radiculopathy cluster directly. Weiner et al. Describe a 4-test cluster. Number 1, an upper limb tension test 1, which is the median nerve, is positive. 2, a positive Sperling's, cervical rotation less than 60 degrees towards the involved side, and distraction relief symptoms. The interpretation: 3 to 4 positive findings meaningfully increase likelihood, and 4 out of 4 can produce a very large positive likelihood ratio, about 30. Okay, but the cluster is not a substitute for the neurological exam. Provocation and mechanosensitivity findings should be interpreted alongside motor, reflex, and sensory deficits to improve the diagnostic precision. The bottom line is this: the cluster raises the probability. Objective motor and reflex deficits support physiologic compromise. Use the cluster to strengthen your reasoning, not to bypass a conduction assessment. Another reply. Go ahead and read this. The correct answer to the question is brachial plexopathy. Radiculopathy should stay limited to the dermatome and myotome of one compressed root, but with brachial plexopathy, disturbances are diffuse, potentially multiple dermatomes and myotomes. Also, plexus problems often involve multiple nerve roots and may lack neck symptoms, so the distribution, not the pain intensity, is the reasoning pivot here. Once probability is established, we must test the pattern. Radiating pain alone is insufficient because radicular pain can occur without neurologic deficit. If the findings are bilateral, non-dermatomal, distal symmetric, or accompanied by upper motor neuron signs, pause and reconsider. Upper motor neuron findings, e.g. hyperreflexia, gait disturbances, pathologic reflexes, shift concern toward cervical myelopathy rather than nerve root pathology. Principle: diagnostic discipline. If the neurologic pattern does not localize to a single lower motor neuron root, reconsider the diagnosis. Localization precedes diagnosis. Accurate diagnosis depends on disciplined localization. Radiculopathy, again, should localize to a single root. Concordant findings in one myotome, one reflex level, and a compatible dermatomal pattern. Plexopathy does not. Dumitriou et al. Described plexopathies as involving, quote, multiple roots or peripheral nerve elements, producing deficits that fail to conform to a single myotomal or dermatomal distribution. Weakness may span multiple levels. Sensory loss may cross dermatomes. Peripheral neuropathy has a different pattern again. England et al. Defined distal symmetric polyneuropathy as, quote, a length-dependent symmetric sensory predominant neuropathy. Symptoms typically begin distally, often in both feet, and progress proximally in a symmetric fashion, non-root based. Here's the summary. Radiculopathy is a single root, asymmetric, and level specific. Plexopathy, multi-root, patchy, non-dermatomal. Peripheral neuropathy, distal, symmetric, and length dependent. Reflexes help differentiate this. Root lesions reduce reflexes at a specific level, whereas plexus or peripheral processes can produce broader or mixed changes. If the findings do not localize cleanly to one root, reconsider before labeling it radiculopathy. Localization precedes certainty. Now we must clearly distinguish between radiculopathy from myelopathy. Radiculopathy produces lower motor neuron findings at a single root level, while a myelopathy produces upper motor neuron signs due to spinal cord involvement. Failings et al. Report that, quote, common signs include hyperreflexia, clonus, pathological reflexes, and gait impairment. These reflect corticospinal tract involvement, not isolated root compromise. Radiculopathy typically presents with hyporeflexia, myotomal weakness, and dermatomal sensory loss, while myelopathy presents with hyperreflexia, Babinski sign, clonus, spasticity, and gait disturbance. Degenerative cervical myelopathy is progressive, and delayed diagnosis may lead to neurological deterioration. If reflexes are brisk rather than diminished, or gait is impaired, suspect a central lesion. Upper motor neuron signs change referral urgency. Root pathology is often managed conservatively. Cord pathology warrants prompt surgical evaluation. Localization here is not subtle, it's critical. Now we move from localization to urgency. Certain findings require escalation, not observation. Imaging is indicated in the presence of severe or progressive neurological deficit. Progressive motor weakness is not a watch-and-wait scenario. Cauda equina syndrome is emergent. New bowel or bladder dysfunction, saddle anesthesia, and bilateral neurological deficits require immediate evaluation. Severe, unremitting night pain may raise concern for serious pathology such as malignancy. Bilateral findings or upper motor neuron signs suggest central pathology and warrant urgent referral. Escalation when the following occurs: progressive motor deficits, new bowel and bladder dysfunction, bilateral neurological findings, upper motor neuron signs, severe non-mechanical night pain. Red flags override probability reasoning. When these red flags are present, they mandate escalation. Clinical reasoning includes knowing when conservative management is inappropriate. Even experienced clinicians make predictable diagnostic errors. First error, equating radiating pain with radiculopathy. Pain does not confirm conduction deficit. Second, over-reliance on dermatomal maps. Dermatomal testing has limited specificity and significant overlap when used in isolation. Third, over-interpreting MRI findings. Degenerative changes are highly prevalent in even asymptomatic individuals. Fourth, ignoring reflex asymmetry. Reflex findings meaningfully improve diagnostic accuracy when concordant with other deficits. Fifth, failing to reassess when findings are absent or evolving. Probability is dynamic. Diagnosis should evolve with the examination. The most common error is premature closure. Radiculopathy is diagnosed through convergence of objective findings, not assumption based on symptom description. Diagnostic discipline prevents overdiagnosis and unnecessary escalation. Most radiculopathies improve with conservative care. Many cases of lumbosacral radiculopathy demonstrate a favorable natural history over time. Most patients with radicular pain improve without surgical management. Management should be guided by irritability, not diagnosis alone. High irritability, prioritize symptom modulation and protection. Avoid repeated loading or aggressive neural tension testing. Moderate irritability, introduce mobility and neural interface interventions. Monitor symptom response and recovery. Low irritability, progress strengthening and load tolerance. Increase functional demand. Reassessment is essential. Escalation is indicated if neurologic deficits progress. Strength and reflexes should be monitored early to detect deterioration. Conservative care is appropriate when deficits are stable. Escalation is required when deficits worsen. Management intensity must match irritability and neurological stability. Clinical practice guidelines provide graded recommendations that help prioritize interventions. The 2017 neck pain CPG states, quote, clinicians should provide exercise for patients with neck pain with radiating pain. Exercise carries a grade A recommendation. The guideline also supports, quote, mechanical intermittent traction combined with other interventions for patients with neck pain with radiating pain. This carries a grade B recommendation. Manual therapy combined with exercise is also supported at a grade B level. Education and activity modification are recommended components of care. The hierarchy is clear. Exercise is foundational. Manual therapy enhances outcomes, grade B. Traction may be added selectively in cervical radiculopathy, grade B. These guidelines do not support passive-only care. They support active rehabilitation with adjunctive manual strategies. Evidence synthesis reinforces structured reasoning. Multimodal, exercise-centered management produces the most consistent outcomes. For lumbar radiculopathy, recommendations differ slightly from cervical presentations. The 2021 low back CPG states, quote, clinicians should use exercise training interventions, including specific trunk muscle activation, for patients with acute or chronic low back pain with radiating pain. Exercise carries a grade A recommendation. Manual therapy is recommended in combination with patients with radiating leg pain. Neuromobilization may be considered when consistent with the clinical presentation. Traction does not receive strong support. Evidence suggests limited benefit for low back pain with or without radiculopathy, so the hierarchy here is clear. Exercise, again, is foundational. Manual therapy may assist. Neuromobilizations may be appropriate, and routine traction is not recommended. Again, these guidelines emphasize active rehabilitation over passive modalities. Informed management aligns with progression based on irritability and neurologic stability. Understanding prognosis informs escalation decisions. Many cases of lumbar radiculopathy improve over time with conservative care. Early clinical improvement is associated with more favorable outcomes. Early response matters. However, not all patients improve sufficiently. Surgical intervention may be appropriate for patients with persistent, disabling radicular symptoms despite adequate conservative care. Progressive motor deficit changes the threshold. Worsening neurologic deficit warrants urgent surgical evaluation. Surgery may accelerate symptom relief, although long-term outcomes are often comparable to non-operative care. Escalation decisions are based on progressive motor weakness, persistent, severe disability despite appropriate conservative care, and failure to improve over a reasonable time frame. Prognosis is generally favorable. Escalation is appropriate when neurological stability is lost or disability remains severe. Clinical judgment integrates time, severity, and neurologic change. And that was our lecture on radiculopathy. I appreciate everybody for watching. And here are the references. Thank you so much.